Hello, friends. So, at the outset, I wish to thank Dr. Swarna Deepak for having me deliberate on this particular talk. The talk that is assigned to me is this multimodal neuro monitoring. So, it's quite a broad topic. So, my disclaimer would be that I'll be giving you a sort of an overview on this whole topic, and it may not be easy to cover the nitty-gritties of every modality in 20 minutes. So we'll see how we take it forward. So I wish to thank my colleague, Dr. Pradeep, who helped me along with this to develop this content. So let's look at the background. So whenever there is a injury to the brain of any sort, and predominantly the context of multimodal monitoring, we would talk in terms of traumatic brain injury or any other cerebrovascular event. So there is a primary injury that happens, which is obviously destined or God intended. But after that, there are a lot of secondary insults that happen, which leads to a lot of cytokine storm within the brain and neuronal death that ensues because of all the inflammatory changes that happen in the brain due to the secondary insult. So these inflammatory changes and the ensuing sort of a process which gets perpetuated is called a secondary insult. So our whole effort is to try and avoid this secondary insult to improve the outcomes in a brain injury. So that is what our understanding is. And there is no single neuro monitoring tool that is currently available which can sort of indicate to you about all the secondary insults and the steps that could be taken. So there is no one single tool. So it is a combination of clinical imaging and multiple other neuro monitoring modalities that we're here to talk. So this picture pretty much summarizes what we are talking when we talk about multimodal monitoring. So you see this brain which is connected to a lot of probes, and this is required to get all the information that is needed from the brain to address the nuances or the injuries that may be setting in to understand the cerebral physiology. And we need a comprehensive information on various domains or dimensions or variables from the brain to ascertain the type of damage that may be prevailing and treatment guided by all the information that we get from various of these modalities. So possibly if neuro multimodal monitoring is asked in an exam for all the trainees who are listening, I think one picture of this nature would pretty much summarize to someone who is looking at your paper that that you have a good conceptual understanding of what multimodal is. So I'll just put in a pictorial format. So very easy to draw this figure. So put up all these wires on the head, and ICP is one neuro monitoring device that we could rely on. Then brain tissue oxygen is another neuro multimodal monitoring, and cerebral blood flow is one monitoring, and transcranial Doppler. Many of the trainees who are listening to this would be doing this. Transcranial Doppler is another modality. Jugular venous saturation is another modality. And brain metabolism, looking at a lot of metabolic parameters within the brain, is another modality. Near infrared spectroscopy, which is available in market, is another modality, and continuous EEG. So in this particular talk, I wouldn't be talking too much on continuous EEG. There's a separate video on continuous EEG which you can go and watch. Most importantly, so you put this figure and put all these probes and put these are the multimodal. So this pretty much summarizes what multimodal monitoring, neuro monitoring is all about. But not to forget, most important things prior to all this, multimodal also includes your clinical dimension, your clinical examination. So I would start with the clinical examination and imaging. So it starts with the clinical examination, followed by imaging, followed by all these neuro monitoring modalities to get all the information which will help you guide the treatment for this patient. So that is what is all about multimodal. So we'll start with the clinical. So clinical monitoring, is GCS good enough? So GCS has been in existence for more than 40 years, and there are certain limitations because someone is intubated. The verbal response, how we quantify, is something that is very nebulous. And GCS of 3, so there is no GCS of 1, as you know. So the most minimum GCS is 3. So when you say GCS of 3, so it may have different connotations. It may not be very clear which sort of a dimension is most severely affected. And GCS does not look at the brainstem function, which is an important limitation of GCS. That's why the newer scores have come called the 4 score, and there is a GCS-T score, which has come, which is useful for training. And when someone is on sedation, analgesia, or neuromuscular blockers, So assessing GCS is a problematic thing. And when there is increase in the ICP, holding of these can lead to deleterious effects. And any GCS does not look into any subtle changes that may be happening, or subtle perpetuation of the neurological injury is not quantified in GCS. So very quickly, we look at GCS P score. GCS P score is essentially GCS plus pupillary reflex score, because GCS does not have pupil. So the score is 1 to 15, as opposed to the conventional GCS, which is 3 to 15. So this is the GCS score, GCS P score. The changes only is in the verbal response. The ones that are marked in red are the changes that are incorporated in GCS P score. And it also factors in, P stands for pupillary. So both pupils unreactive to light score of 2, one pupil 1, and neither pupil 0. So that's the sort of a score in GCS P score. Then very quickly we looked into the core score, which is full outline of unresponsiveness score. So very similar to GCS. E0 is no response, no eye opening to the pain, and there is eye opening to the pain, or verbal commands, tracking of the eyeball, and oriented and following the commands. And motor response is very similar to GCS, so we won't pay too much attention to this. But in core score, what importantly it adds on, as I said, GCS does not factor in brainstem reflexes. In core score, there is incorporation of brainstem reflexes, where B0 is basically there is no cough reflex, there's no corneal reflex, and there is no pupillary reflex. B1 is where there is no pupillary reflex and no corneal reflex. B2 is either pupillary reflex is present or either corneal, and one of them is absent. That is B2. B3 is where where there is asymmetry and dilatation. B4 is normal pupillary and corneal reflexes present. So it factors in the brainstem function. It factors in three elements. It factors in the cough reflex, cornea reflex, and the pupillary light reflex, and that is quantified in the core response. And then there is an apnea also. So R0 is apnea. R1 is where there is a patient initial breath trigger is there, and R2 is where there is irregular breathing, and R3 is the Cane-Stokes breathing, and R4 is normal breathing. So these are the components of core. So then we'll slowly move on. There are certain advances with regards to records. So we know for sure that when nurse looks at the pupil, there's a crude way of estimating the size of the pupil. So pupillometry is more advanced sort of tools that you use to really quantify the reactivity index of the pupil. So you use such machines to look at the pupillometry. So when the normal ICP is there, then your pupillar response, as you would all agree, is very brisk. So the briskness is there should be 34 to 36% constriction of the pupil. If there is less than, or if ICP is high, there is less than 20% of the pupillary sluggishness is there. So there is no brisk reduction of the pupillary size. So less than 20% reduction in the size tells you that ICP is more. And based on this, they have come out with neurologic pupillary index. So where they look at the briskness of the pupillary reflex, they look at dilation velocity, they look at latency. So if NPI, which is neurologic pupillary index, is more than 3, it is normal. If it is less than 3, it is abnormal. So these are some of the newer nuances that are evolving in multimodal. And I have to mention the clinical indices to mitigate the secondary insults is most important. So in our ICU, we follow the 7 normos principle: normoxia, normocapnia, normovolemia, normotension, normothermia, normoglycemia, normosmolality. So this is something which has to be dinned into every nurse who's looking after the patient, that these normos. So in our chart, for any neuro patient, we write maintain 7 normos, and every nurse in my ICU knows what these 7 normos are. And these are to make sure that secondary insults are not perpetuated, or we mitigate the secondary insults. I won't delve into the details. So we have finished clinical, where we have spoken about GCSP, 4 score, and then we spoke about pupillometry and 7 normals. Then we'll move on to the imaging. So imaging, you have various classifications. The common one that many of you would be aware is Marshall classification from grade 1 to grade 4. So grade 4 is worst prognosis. So I won't go into detail. Very quickly, I'll rush to it. Grade 1 is where there's midline. So basically, any CT grading, they look at the 3 components. One is they look at the midline shift, they look at the effacement of the systems, and they look at the evacuable hematoma which is present. So grade 1 midline shift is absent. So it's very, so your whole problem starts from grade 3 when the systems get effaced, and grade 4 where midline shift is more than 5. If you remember that, that should be good enough. But the whole problem of imaging as a neuro modality is it gives a snapshot, does not track the sequence of or progression or dynamicity of the progression of the injury is not factored in. and transporting the patients every time to CT comes with its own set of risk, and it can be detrimental. So I spoke about this. I won't go into details of this. There is a separate video on this. So basically, remember from grade 3, you have effacement of the systems. Grade 4 is where you have midline shift of more than 5. So after this, and grade 5 and grade 6 is where you start having hematomas and evacuable hematoma. Why is this important? Because it has a mortality correlation. When someone is in grade 3, where there is effacement of the systems, mortality goes up to 40%. And once they go to grade 5, grade 6, and as you see, grade 6 has a very high mortality. Then there are newer scores like Rotterdam. So as I said, any score, they factor in the systems, they factor in the midline shift, and they factor in the evacuable hematoma. And same is in the Rotterdam classification. And this is the mortality correlation with the different scores. Let's not dwell too much into this detail. Just remember these names. So these are the newer sort of a imaging classification. Then you have a Helsinki score, so which basically looks into the hematoma size, and the scores are given as you see: 2 for the subdural, epidural gets higher score of 3, and a big intracranial hematoma gets score of 2. And then it looks at the intraventricular hemorrhage, which gets much higher score, and evacuable hematoma more than 25 gets 2. And basically, they look at the systems. The total score is around 3 to 14. Then there is something called Stockholm. Why am I speaking about Helsinki and Stockholm? It is shown that Helsinki and Stockholm are better predictors of outcome because they take in more variables. So Stockholm's CT score takes into all this consideration, but it also takes into factoring in the diffuse axonal injury, and it looks into SAH present in the convexities with midline shift, SAH in the basal cistern with midline shift, and it looks at diffuse axonal injury, and it computates all this and gives you a score. So basically, they have found that the outcomes are better determined by Helsinki and Stockholm. So all these videos have been dwelled in a little detail in another video. So this is rushing into Rotterdam. So imaging, you have different, what we follow is very typically conventionally Marshall. But remember, there are other scores like Rotterdam, Stockholm, and Helsinki, which also have a good prediction. So if you remember that, that's good enough. So we'll move into now real neuro monitoring modalities, ICP and cerebral perfusion pressure, which every listener is aware of. So what are the advantages of ICP? ICP, the cost is low now. It has reasonably good accuracy and reliability. The big advantage of ICP, especially, you have different ICPs. You have epidural catheter, you have subdural catheters, you have intraventricular. The commonest one that are used in our ICUs is EVD because it sits in the ventricle. The advantage is you can drain the CSF, which is also having therapeutic advantage, and we'll talk a little bit about that. But ICP is not that does come with its own set of risks. 8% of them can end up in complications. They can have hemorrhage at the site of insertion. They can have risk of infection. Then ICP catheters can get blocked, and the risk proportionately increases with the longer duration of stay within the brain. So the more longer it stays, higher is the risk. And there are these trials which have shown that the risk is much lesser if EVD is there within 5 days, and the more longer it stays, the higher is the risk. So that is something you have to keep in mind. So what is the whole science of ICP? Because there's a huge debate whether really ICP makes a difference. So very quickly, we'll rush into ICP monitoring versus no monitoring. As many studies are there talking about advantages, that many studies tell us there is no real benefit in ICP. So these are the 4 studies from US and UK which have said ICP monitoring leads to better outcome. And less than 20 millimeter mercury is what we have to make sure that ICPs are maintained less than 20. More than 20 millimeter indicates that your cerebral perfusion pressure is being compromised, and you have to put in measures to reduce the ICP. And it is shown that, as I said, ICP remains longer, more than 3 days, the risk of infection proportionately increases. So these are studies telling ICP is beneficial, but there are 6 randomized controlled trials, 12 cohort studies, which say use of ICP may be helpful in reducing AKI, favorable outcome, but no effect on mortality, length of stay, or duration of mechanical ventilation. So the bigger chunk of studies really are telling us that either be it have an ICP or no ICP, it did not make a difference with regards to ICU length of stay, duration of mechanical ventilation, and mortality. And so ICP and CPP are correlated. So CPP is MAP minus ICP. So what is the optimal cerebral perfusion pressure is something that we use to target to reduce the risk of ischemic penumbra that happens in ischemic stroke, And maintaining optimal CPP is shown to reduce the inflammatory cascade or the cytokine storm that happens within the brain. So because there is ongoing vascular ischemia in the brain or cerebral blood flow is reduced, there is more ischemia and more inflammatory process. And optimal CPP helps in reduce the brain inflammation. But the whole debate is what is the right CPP? It should not be very high. So the number for all the trainees to bear in mind is CPP to be maintained 50 to 70. There is huge debate whether 60 is better or 70 is better, but definitely not more than 70, not less than 50 is your take home message. So Lund therapy says that if it is more than 70, it causes vasogenic edema. So our whole intent should be to keep CPP less than 70. And when there is vasogenic edema, the intracerebral volume also increases. So our whole intent is to reduce CPP less than 70 to reduce vasogenic edema, reduce the intracerebral volume, and reduce the ICP. But how about 50? If it is less than 50, it is very clearly shown from the studies that there is reduction in the cerebral blood flow. More than 60 is what is desirable because it is shown to maintain good brain tissue oxygenation and avoids brain hypoxia. So 60 is your magic number. 50 to 70 is the range. More than 70 is bad. Less than 50 is reduced cerebral blood flow. 60 is a good number. We'll talk a little bit detail as to whether 60 is better, 65 is better, so on and so forth. So CPP more than 70, there is study to show that there is 5 times increase in the risk of ARDS and there's no benefit in outcome. So more than 70 is bad, less than 50 is bad. So in exams, write 50 to 70 is safe. And the quintessence is if auto regulation is well maintained, you can maintain more than 60 and up to 70. But if auto regulation is not good, then maybe you should stick around 60 to 65 is the range is what you can take home as a message. So now we'll, for all the trainees, just look into what does the ICP trace looks like. So ICP trace has a vascular pulse and a respiratory pulse. It is pulsatile and it correlates with the respiratory and cardiac cycle. And it has different waveforms, and these waveforms are typically shown in your exam. And you are asked to identify what are the three waves. There is P1, P2, P3 wave. As the name P sounds, it's the pulsatility wave, or the P1 is the percussion wave, which is due to the pulses that are reflected from the plexus around the carotid. And the P2 is the very important wave, which typically indicates the ICP and it has a correlation with ICP. It's called the tidal wave. And this is due to the pulsations that emanate from the cerebral vessels coming out of the cerebrum. So P2 is really indicative of how your ICPs are behaving, and P3 is due to aortic valve closure. So these are the three waves which are typically shown in exams. So it's easy to remember. Please remember this. Then there are these different abnormal waves called the Lund waves. So there is Lund A waves, B waves, and C waves. A waves is very bad. So A waves really indicate very high ICP, 50 to 100, and it really tells you that there is an impending herniation. And these waves typically last for 5 to 10 minutes. And there is Lundberg B waves, which look something like this, which indicates that highest ICP is around 20 to 30, and it lasts for much shorter time of 1 to 2 minutes, and it indicates there is evolving cerebral injury. So the Lund C waves is not of much significance, and it is the variation due to the blood pressure variation, and it correlates with the blood pressure fluctuations and does not have any clinical significance. This is for all trainees to understand what are the abnormal waves that you would see. So we'll talk very quickly on what are the other derived indices from ICP. So from ICP, it's not only the ICP measure that we would get, there are certain derived variables. You obviously with ICP, you get an absolute ICP, you get the cerebral perfusion pressure. Then there's something called pressure volume index. So this is very important. See, like in oxygen dissociation curve in ICP, if you see this ICP plotted against the volume, there is a critical phase at which the pressure enormously increases and exponentially increases. So this is related to the volume. So at this critical juncture, it is terribly important if you have a EVD day, a small drainage of CSF significantly reduces your ICP. If you look at this graph, there is a critical juncture at which the ICP enormously or exponentially increases, and that is a phase when it shoots up. So the simplest therapeutic maneuver is to drain a little bit of CSF and the pressure significantly comes down, and that is the value of pressure volume index. And these are plotted, and they are plotted against the pulsatility flow within the blood vessels, and there is a good correlation how your pulsatility flow also gets affected, which is indicated as correlation coefficient. So those are the derived indices from the ICP monitor. Then there's something called CVP reactivity index, which is how the ICP responds to changes in the arterial blood pressure. So this is called, cerebrovascular reactivity, which is also called PRX. As you see, cerebrovascular reactivity, there is increase in the cerebral perfusion pressure. Your blood pressure, the cerebrovascular blood vessels also react with increasing in the constriction. At one stage, they reach a threshold where they no longer react and they become non-responsive. That is called as cerebrovascular reactivity positive, where it indicates the vessels are reacting to the changes in the cerebral blood flow. And at a very critical stage, they stop reacting when it becomes non-reactive, where it really tells you that it is associated with deleterious damage or irreversible damage to the brain, and the vessels are no longer reacting to the changes in the cerebral blood flow, and your autoregulation is impaired. And that is what are the derived indices from the CVP or cerebrovascular reactivity index. So, and it refines your CPP oriented treatment. So very quickly, so now we have spoken about ICP monitor, but in ICU as an intensivist, you cannot put an ICP monitor, you can only monitor, but what the tool you have is your optic nerve sheet diameter, which I'm sure most of the trainees would be using. Very, very simple technique. Use a vascular probe, put it on the eyeball, and you would see an image like this. You just have to remember two numbers, 3 millimeter and 5 millimeter. So you draw a line 3 millimeter from the optic chiasma and take the measurement. So adults, it should be less than 5 millimeter. If more than 5 millimeter indicates there is high ICP and it is 100% sensitive. If it is more than 5.7 millimeter, it's 100% specific for increase in ICP. And the graph shows something like this, where it increases up to 7.5, after which it plateaus. So very easy test. 3 and 5 is what you should remember. 3 millimeter down the optic chiasma. You take the measurement transverse diameter. If it is more than 5, it indicates there is high ICP. More than 5.7, it is in a critical phase where ICPs are definitely higher. And you have to take 2 to 3 measurements. So when it comes to ICP, so the whole debate you can summarize as there is no level 1 data to give recommendation whether ICP will make a difference. Level 2 recommendation is avoid CPP more than 70. And I told you repeatedly, more than 70 is bad. It increases the risk of ARDS. Level 3 is less than 50. It clearly indicates there is reduced cerebral blood flow. 50 to 70 is safe. But what is the number you'll pick up between 50 and 70? There, the question is, when there is a good autoregulation. What is autoregulation? We looked at various indices, the cerebrovascular pressure reactivity, and I'll talk about few other things. If there is a good autoregulation and CPP is present, CPP elevation, you can maintain more than 65 up to 70, better outcome. But if there is defective autoregulation, then you should try to maintain CPP around 60 and not more, because that leads to better outcome. So this is the consensus that we have derived from all the studies put in together. So 60 to 70 seems to be a good number. If the autoregulation is good, go up to 70. But if autoregulation is not good, stick around 60 is your gospel from the available evidence. So very quickly, next 2-3 minutes, I think I have 1 or 2 minutes. So jugular venous pulse oximetry. So this looks at the balance between oxygen delivery and oxygen consumption, and the changes in the jugular venous oxygen saturation is correlative to the cerebral blood flow. And the number to remember is less than 55%. It indicates that there is reduced cerebral blood flow, and it is associated with poor outcome. If jugular venous saturation is less than 50%, it indicates that 13% of the brain is ischemic. And it has a reasonably good correlation with cerebral perfusion pressure, because if your cerebral perfusion pressure is less than 60 millimeter mercury, it is shown to have a correlation with reduced jugular venous saturation, and it has a good correlation with arteriovenous difference of lactate. So these are the studies to substantiate that jugular venous saturation has a good relation with the cerebral blood flow, and so on and so forth. And it basically helps you to optimize and titrate cerebral perfusion pressure better. So now we'll move quickly to the brain tissue oxygen. So the brain tissue oxygen is basically looking at the oxygenation within the brain, the value. So jugular venous, you remember the value should be more than 55%. So brain tissue oxygen, the number is 35 to 50 millimeter mercury is what you should maintain. If it is around 5 to 20 millimeter mercury, it indicates that brain is ischemic, and low brain tissue oxygen is associated with poor outcome. And brain tissue oxygenation also has a good correlation with cerebral perfusion pressure. So when I say auto-regulation, what does that mean? So this is a very simple tool you can use. So when there is increase in the systemic PaO2, And this is correlating to the increase in the brain tissue oxygen. That it means there is brain tissue oxygen reactivity is present and autoregulation is present. So basically, autoregulation is where increase in the blood pressure leads to increase in the CPP, increase in the systemic oxygenation leads to increase in the brain tissue. So when there is a brain which is responding to increase in certain systemic variables, that we call it as autoregulation. So when there is increase in the systemic oxygenation, increasing in the brain tissue, is brain tissue oxygen reactivity, and it is shown to have a good correlation with cerebral blood flow, and this is disturbed in severe traumatic brain injury. So, but there are studies to contradict this. So there is a study from the Spain which says brain tissue oxygenation has no correlation with the cerebral perfusion pressure. And there is another study from US which tells you that brain tissue oxygen used as a target to treat to optimize cerebral perfusion does improve outcomes. There are no big studies. There are studies to say brain tissue oxygen may be useful tool as an adjunct to determine whether cerebral perfusion is happening well. So just last couple of slides, microdialysis. Microdialysis, as the name sounds, you put a probe, connect to the point of care and look at the CSF content of glucose, glycerol, lactate, and pyruvate. Basically, presence of more lactate in the CSF tells you there is a lot of ischemia happening. And changes in this basically it is shown that the lactate raise happens first even before evidently cerebral perfusion pressure comes down or your brain tissue oxygen comes down or jugular venous saturation comes down. Even before all this, lactate is what shows high. It is similar to sepsis where lactate goes up within 1 hour even before your systemic parameters are compromised is what is the principle. So, and this can basically help you to prognosticate, help you guide management, and help you optimize the treatment. And they've looked at different ratios. Lactate and pyruvate ratio increase as shown to associated with the poor outcome. So this is a study by Finland where they showed that increase in the lactate had a good correlation with CPP less than 50 or more than 70, which is very useful. So if lactate is high, either you have to believe there is vasogenic edema setting in with increase in ICP because CPP has gone more than 70, or it indicates it is less than 50. And CPP as a correlative of microdialysis, there's no consensus because there's no big studies. There are small studies telling you that it is a useful adjunct. So very quickly, I'll talk about transcranial Doppler. I'm sure some of you may be using this. So transcranial Doppler pulsatility index also has a good correlation with CPP, and it can help you identify the patients who are at increased risk of ischemia. And changes in the blood flow and its correlation to changes in MAP can be indicated with transcranial Doppler. Here we look at the flow velocities in the middle cerebral artery, which tells you whether there is autoregulation thresholds are good or bad. And there is something called driving pressure, which is the mean arterial pressure minus critical cerebral pressure. All these are derived indices from the transcranial Doppler, which tells you whether your cerebral blood flows are getting compromised. And in near infrared spectroscopy, which is a very simple non-invasive tool, and this also has shown to have good correlation with cerebral vascular pressure reactivity. So we need bigger studies to conclusively use this, but all these are some of the multimodal neuromonitoring which can be used as an adjunct to determine how your cerebral blood flow is happening. So coming to my last conclusion slide. So how much ever we talk about multimodal monitoring, I think the whole conclusion is there is no one single tool. We can use all this information coming in from these devices as an adjunct to the clinical and to the imaging sort of a correlation to guide us with regards to prognosticating and with regards to treatment goals. So my conclusion is the cerebral blood flow with metabolism, like in ARDS, it's like ARDS. So there is a ARDS happening. So if there is a primary brain injury, so the cerebral blood flow and the metabolism is very heterogeneous. It's not like whole brain, the cerebral blood flow is compromised. There is one area which may be hyperemic. There is one area which may be ischemic. So it's very heterogeneous with regards to place and with regards to time, because at the outset, blood flow may be good, but over 6 hours, the blood flow may be compromised. So it is very dynamic in nature. So it changes in place and in time. And even so is the case with CPP and ICP requirement, because there is no absolute value, because the requirements of higher CPP or lower CPP is different in different place and different times. So that is where the whole challenge, we can't look at brain as one homogeneous unit. It's a heterogeneous. At some places, CPP may be very high. At some places, CPP may be very low. So that is a huge challenge. That's why we need multimodal monitoring. And jugular venous saturation, brain tissue oxygenation, and lactate, CSF lactate is a useful tool which may help to aid optimize your cerebral perfusion pressure and reduce ICP. So my summary is still this figure. This pretty much summarizes what multimodal monitoring. So basically, whatever tools you have, clinical remains gold standard, imaging remains most important, and to use other adjuncts, anything you have in ICP. If you have ICP, use ICP. If you are using jugular venous, I have used couple in Australia where I'm aware of the nitty-gritties in using jugular, because jugular venous saturation, the probe keeps getting displaced. But near infrared spectroscopy is available in India, so we use for a couple of patients in on an experimental mode. And continuous EEG is possibly the way forward. There's a separate video you can see. I didn't cover in the paucity of time. So this pretty much. So if someone asks you an exam, multimodal neuromonitoring, just put one head, connect to all these wires, show all these variables. That pretty much tells examiner that you have a good conceptual understanding of what multimodal monitoring. There's no single tool. It's all the information that are derived from this are all telling you in which direction your brain is behaving. So thank you one and all. So you can visit my website www.drpradeeprangappa.com to rehear to this, because there's a lot of information that I have regurgitated. So, and many of these are covered in other smaller videos. So you can go and visit and enlighten yourself. So thank you one and all.